I was able to hold like a 220 beat per minute heart rate for 20 to 30 minutes, and it got to the point where you get lightheaded, you'd be ready to pass out.
I always know that a cardiologist doesn't really know what they're talking about with me when they tell me that they've seen a lot of cases like mine.
I'd get dizzy, my head would spin, I couldn't breathe, and I was dying.
We're about to meet Jerry Allison, Joanne Wallow, and J.J. Zevenbergen. 3 people with 3 different stories and one problem in common. All 3 had heart conditions that kept them from living life to its fullest. But today, they all have one more thing in common. They were successfully treated and have fresh takes on the future, thanks to the physicians and staff at the UW-Medicine Regional Heart Center.
The UW-Medicine Regional Heart Center is unique. Not only do we have expertise across a whole variety of different parts of cardiology, we have people who are world's experts in a lot of different areas as well, including electrophysiology, the treatment of adults with congenital heart disease, the treatment of patients for very complex surgical disease that require surgery.
It's an incredibly unusual collaboration between specialists with both national and international reputations.
I think my favorite part about it are the faculty and my team members, the nurses, the medical assistants, the ECG techs, the echo lab. Everybody who works there has a very patient-first team attitude.
Our heart specialists are all located in the same space within feet of each other. So if we have a question that we need a surgical opinion on, we can get that immediately. The face-to-face interaction is obviously critical.
Physicians at the UW-Medicine Regional Heart Center work in collaboration, seeking the best solutions within a range of specialties. Together, they weigh treatment options for each patient. Some patients might need open heart surgery, some less invasive procedures using new emerging technologies, or perhaps medication. And some patients require a combination of therapies. Whatever the answer, the providers at the Regional Heart Center discuss and consult, fully focused on patient care. It's a strategy that successfully works.
We have not only the broadest spectrum of care in the Pacific Northwest, but we have the very, very best surgical and cardiology clinical outcomes.
And aside from top-notch, one-stop cardiovascular care, the Regional Heart Center offers something else. The doctors and support staff who practice here are members of a world-class academic and research institution.
UW-Medicine is known internationally as probably one of the best medical programs in the nation, with some of the best physicians in the nation, if not in the world. And also the University of Washington as a research center is world-renowned as an academic institution.
And because we're an educational system, that keeps us on our toes. We have to stay up to date on all of the new advances, and so the patient really gets the benefit of the highest academic integrity that medicine can offer.
We have research here all the way from the very basic science aspects of research all the way into the development of technology to deliver patient care. Well, I think it's a unique advantage because, again, the focus is not quite what it would be elsewhere. The focus here is to try to not only deliver good patient care, but to really push the envelope so that we can develop the new and next techniques.
If I had not have been near one of the premier heart centers in America, I would have been dead. There is no doubt about it.
Jerry Allison is one patient who credits the Regional Heart Center's world-class research with saving his life. A former recreational pilot and Air Force veteran, Jerry lives in Spokane and receives his medical care through the Veterans Health Administration. He's had a heart attack, 4 balloon angioplasties, and open heart surgery for a quadruple bypass. So when his heart valve narrowed and calcified to the point of needing replacement, another open heart surgery presented poor odds.
There was less than a 50-50 chance of me surviving.
Given those odds, Jerry's Spokane VA cardiologist sent him packing to Seattle. She had heard about a clinical FDA trial for a type of valve implanted without the need for open heart surgery. So Jerry went to see physicians at the Regional Heart Center who were researchers for the national trial. Under study is the valve, new technologies for placing the valve, and new options for the team care of patients such as Jerry with complex heart problems.
It's testing a hypothesis, for one thing, that newer technology can make an impact and innovation can make an impact in morbidity and survival of patients with very advanced disease who are elderly, who are normally not candidates for surgical intervention.
Jerry had several unique issues. One was that he had a very severely narrowed aortic valve.
The aortic valve sits in front of the heart, and it is essentially a one-way valve to allow the blood to flow from the muscular portion of the heart, the left ventricle, into the aorta and feed the heart vessels of the heart itself, the brain vessels, and the rest of the body.
Jerry's heart suffered from aortic stenosis, meaning the aortic valve was narrowed and stiff due to calcification. The flow of life-sustaining, oxygenated blood to his body was restricted.
It got to the point where I was just immobile. I just couldn't do anything.
So patients with symptomatic aortic stenosis, even with the best of medical therapy, are expected to die of their disease within the next 2 to 5 years. The mortality is in the order of 80%.
Normally, valve replacement involves open heart surgery, but in Jerry's case, the risks were too high. Accepted into the research study, he came to Seattle and underwent a catheter-based procedure. He now has a new valve put in place through the use of a long tube, a catheter inserted into a blood vessel in his groin. The catheter was carefully snaked up inside the vessel and into his heart.
This is the aortic valve here. So this area here is the area where we're going to try to replace this valve as we perform the procedure. So during this procedure, what we have done here is place this tube from the right groin up and going off the screen here and around, and then placed it just above the aortic valve.
First, a large balloon is inflated, pushing the old diseased valve out of the way. This makes room for the replacement valve.
This dark object here is actually the aortic valve prosthesis. It's the new valve that's going to go into place. So once we get this where we would like to have this valve located, this is mounted on a balloon as well. The balloon then inflates, but this time it inflates this valve so that the valve is then left in position.
We're not replacing the old valve, we're putting a new valve within a diseased valve. So a completely new concept.
The prosthetic valve, made of tissue, is encased within an expandable cage. Once the cage is expanded and the valve is in place, oxygenated blood pumps one way through the replacement valve.
And so the valve allows the blood to go from this chamber up into this chamber to the aorta. And the valve opens when the heart beats, and it closes when the heart's resting.
All airplanes in the world that I would not want to fly, that's one of them.
The GB.
Yeah. It could flip out from you in just an instant.
Jerry Allison might never again pilot an airplane, but he can walk through an air museum, share his passion for aviation history, and enjoy every moment of it. All thanks to an experimental valve and a world-class team of heart specialists.
I would have been dead a year ago. This procedure was done about a year and a half ago now. It definitely has given me another year and a half of good quality life. Not just pick and stab, but good quality. How lucky can one person get?
While Jerry wanted a continued lease on life, Joanne Wallow's hope was to create new life. She and her husband wanted to start a family, but for Joanne, that decision came with risks.
Well, I found out when I was 12, actually, that I had this heart condition.
In her case, one of her arteries, instead of coming off of the aorta, came off of the pulmonary artery, which is actually where all the blue blood is headed out to the lungs. So that particular artery is not getting a sufficient oxygen flow down into the heart muscle.
At the time, Joanne was just a kid living on the East Coast. Her chest hurt, she was short of breath, but no one dreamed it could be her heart. Joanne finally demanded to see a cardiologist.
And it was one of those things where they were like, how are you still alive? You shouldn't be here today. And so they rushed me into open heart surgery the next week.
Although the surgery saved her life, Joanne's heart problems didn't end there. Her chest pains continued. Doctors discovered restricted blood flow to a portion of her heart muscle. An artery was malformed, bulging at the top of her heart and narrowing as it approached the front of her heart.
She ended up with some significant narrowings in the artery that feeds the front part of the heart that she had dealt with stents initially, balloon angioplasty stent, a bypass graft. So here she has this thing that she was born with that's incredibly uncommon. And then she shows up with something that's just a bit more of a typical adult problem, but for very non-typical adult reasons. And because she has it for a different reason than the high cholesterol, high blood pressure genetic thing, you can't treat it exactly the same way.
Joanne came to the Regional Heart Center when she was pregnant with her first child, Carter. She had been a patient of an adult congenital heart disease center in Boston. When she moved to Seattle, her Boston cardiologist said, "You're in luck. Seattle has one of the few adult congenital heart programs in the country."
And so it's just great to be able to be up here and to be able to have that kind of a clinic that really can take care of me the best way that I need to be taken care of.
And so she came in already really well aware that she was best served by being in an adult congenital heart disease program, and especially for what she was hoping to do, which was to have kids. 5 of them, in fact. Your equivalent of a marathon is being pregnant, and you're on marathon number 2.
Number 2.
Dr. Karen Stout directs the Adult Congenital Heart Disease program at the Regional Heart Center. She's trained as an adult cardiologist, but has additional training in congenital heart disease. She spends half her time at Seattle Children's Hospital and half time at the University of Washington Medical Center.
She asked me how many children I want to have, and I told her I wanted to have 5 kids, and she was like, "Oh, I need to go on some ulcer medication." But she's great. She's got my back, and she's able to give me the kind of care that I need.
Joanne is also seeing a high-risk obstetrician at the University of Washington Medical Center. Now into her second pregnancy, her entire medical team works to minimize any risks to her fetus, her heart, and her long-term health.
So particularly for congenital heart disease, it is such a team sport. And you really have to have people who are really good at what they do involved in the care of these patients, and people who are willing to say, "That's not what I do, I need to involve somebody else with more expertise."
So when they did that bypass graft, it comes down here and inserts into your native blood vessel, which is this chunk down here. Mm-hmm. And that's a really small, tiny, very thin blood vessel.
Those of us who do congenital heart disease, and particularly who take care of adults, see a lot of times windows of opportunity where we could have intervened on something before it kind of got out of control. If you don't do congenital heart disease a lot, you may not necessarily recognize those windows of opportunity, or you may not necessarily understand the underlying physiology and how it's different from generic adult heart disease.
So fixing that area isn't the point. Making sure that the areas around it and any other areas end up as healthy as they possibly can be is really our goal.
Today, Joanne is being treated with medication. There are few surgical options currently available to correct her malformed artery. But for adult congenital heart disease patients needing cardiac repair, surgeons might turn to Dr. Michael Kim for help. Dr. Kim leads a regional heart center effort to catalog heart pathology and produce 3-dimensional heart models. He uses 2-dimensional images such as CT scans, MRIs, and echocardiograms. Then he transforms these 2D computer images and places them as 3D models into the hands of cardiologists and surgeons. For now, the models are used to educate both patients and doctors about common heart malformations and heart disease. In the future, these models could represent an individual patient's heart. They might be used to design a custom-made heart valve or a custom-made plug to repair a cardiac hole. For adult congenital heart patients such as Joanne Wallow, 3D heart models could help doctors understand the very unique structures of their very unique hearts.
With advances in technology, in surgery, and in critical care, many children with congenital heart disease are now surviving into adulthood, which really wasn't the case 20 years ago. Many of these patients as children have had multiple corrective procedures. Things are connected to things that usually aren't connected to certain things. And having a really fine understanding of what the anatomy is probably the biggest challenge in taking care of these patients before you can figure out how to treat them. CAT scans, MRIs are great in elucidating that, but what I found is that really having a 3-dimensional model of their heart tells me much more about the anatomy and about what can be done to treat pathology than just seeing images on a screen.
While Joanne lives within an easy drive of the UW-Medicine Regional Heart Center, others like her might see their hometown internists or cardiologists. Regional Heart Center doctors are team players on a multi-state level. The goal is to form true partnerships with physicians and their patients throughout the Pacific Northwest. The Regional Heart Center professionals are intent on bringing the best leading-edge treatment to adult congenital heart patients, no matter where they live.
So what I'd like to see is that all patients, all adults with congenital heart disease have access to our center, that their cardiologists have access to us, and we educate their cardiologist about them. They may not know everything about congenital heart disease, but they can know about Joanne, for example, and be able to work as a partner so that we can really raise the quality of care for adults with congenital heart disease in the region, and hopefully ultimately serve as a model nationally for how you can do that in a big geographic area where there's people scattered all over who need your services.
Want to help me out? Yeah, that was a good job. That was perfect.
Between my cardiologist, Dr. Stout, and my OB, I feel like I have two of the best doctors in the world with the best resources that there could possibly be for me.
I could beat him on the standard surfing, but as far as paddling goes, he's got me pretty whooped still.
Meet John Zevenbergen IV, also known as JJ. He and his dad, John, share a passion for downhill skiing, a history of competitive rowing, and a love for besting each other on a paddleboard. But these two share far more than an athletic, competitive spirit. They both had hearts that misfired, causing irregular beats, a condition called arrhythmia. John's would flutter and beat out of sync. It wasn't life-threatening, but it was uncomfortable, and it affected his activities.
It would it'd be an incomplete heartbeat, and it would be a real, like a flutter. It was always kind of like, hopefully I don't have something like that going on, like if you're hiking. Say you're driving. It was something that was always in the back of my mind. You'd worry about it.
For JJ, the problem was more serious. He had two arrhythmias, atrial fibrillation and atrial flutter. His heart would fire up and beat at a dangerously high rate, the top part of his heart out of sync with the bottom part. It was a problem that increased in frequency when he started competitive college rowing.
I started noticing, hey, I can hold a 220 beat per minute heart rate for 20 or 30 minutes without a problem.
JJ had the most common heart arrhythmia, but because he would suddenly have such rapid heart rates during exercise, it was also dangerous. It wasn't simply uncomfortable, it was threatening his life.
My role in the Regional Heart Center is as a cardiac electrophysiologist.
Dr. Robert Rowe and Dr. Jean Poole head up what, in simplistic terms, is the electrical program at the Regional Heart Center. It's called the Cardiac Electrophysiology Lab and Arrhythmia Service. This clinic treats a range of heart disorders that originate when the electrical impulses controlling the heart's muscles and its pumping actions misfire.
The heart is a very interesting organ. It's not only a pump, but electrical signals kind of dictate when in sequence the pump activates. And there are a lot of things, both normal and abnormal, that can either increase or slow the heart rate down.
Often our therapy for those patients is indeed interventional and in fact can be surgical, such as with the implantation of a pacemaker or an implanted cardiac defibrillator. But we also perform catheter-based procedures that are used to identify the source of an arrhythmia within a patient's heart and allow us to perform catheter ablation procedures.
For some patients with abnormal heartbeats, medication is the first line of treatment. But in recent years, minimally invasive techniques offer non-medicinal therapies. Dr. Rowe recommended one of these techniques, called catheter ablation, to both JJ and his dad, John Zevenbergen. JJ was first.
So we discussed medication therapy in great detail. And for John, that was a very poor choice for him because he didn't like the idea of taking medications long term.
He was able to be more like, hey, I see you're an athletic guy. I see medication may not be the route for you.
Young men like JJ are a little bit outside of the typical patient that we see with atrial fibrillation. When it happens, you want to make sure that there isn't any underlying structural heart abnormality. So he was evaluated for that very cautiously. It was very clear that he just had a very normal athletic heart.
Dr. Rowe treated JJ's heart arrhythmias by performing 3 separate, very conservative procedures. Each time, he carefully burned small areas of tissue inside JJ's heart. In more typical older patients, the procedure is more aggressive.
Over the last couple of decades, it was discovered that AFib initiates from extra heartbeats that come from these tubes that drain blood from the lungs called the pulmonary veins. And these tubes have little projections of muscle into them, and for reasons that are not precisely clear, these little extensions of muscle in the pulmonary veins fire out of turn. So, if sinus rhythm is a symphony, there's a rogue violinist playing and making, horrible music.
To correct the horrible music of atrial fibrillation, Dr. Rowe burns and destroys small areas of tissue inside the heart, cutting off the ability of the pulmonary veins to send out-of-rhythm electrical impulses. This silences the off-key, out-of-sync heartbeats. Using small incisions in the groin and the neck, long tubes or catheters are inserted through blood vessels and carefully threaded into the heart's interior. These catheters monitor, map, and ultimately repair the heart.
So this is a three-dimensional mapping system, and you'll see very shortly here, I'm going to make a quick rendering of his anatomy by moving my catheter around on the inside of the heart.
The first step of an ablation procedure is called three-dimensional magnetic electroanatomic mapping. It's a way to image each patient's interior heart anatomy and track where and how the muscles are electrically misfiring. Magnets under the operating table track the position of a loop-shaped catheter in 3 dimensions. When the loop gently touches the inside walls of the heart, a 3D map of the internal heart structure is created in real time. The loop also captures and maps electrical signals and displays them on a computer screen. Once an image of the heart's internal anatomy is created and its electrophysiology is clearly understood, the workhorse catheter comes into play.
Okay, so now the icon of the catheter turns red when our ablation is on.
This is the catheter that completes the ablation. The tip of it delivers concentrated radiofrequency signals. When the tip of the catheter comes in contact with tissue, the result is heating and a small burn.
The surface area that the catheter is in contact with the inside of the heart lining obviously is very small. And the critical part of the procedure is to place a series of burns around the pulmonary veins.
The burns create a circle of dead muscle between the pulmonary veins and the heart. Misfiring electrical impulses can't get through the dead tissue. That out-of-tune and out-of-sync violinist is enclosed in a soundproof room and no longer part of the symphony.
Carefully, we place lesions all the way around the pulmonary veins and essentially wall off that rogue violinist so that you can't hear him anymore and that the heart kind of beats in tune and the music goes on.
And we still need to figure out the music for the ceremony, which is very important.
We've got to get our dance moves down too.
Yes.
For J.J. Zevenbergen, the ablation procedure completely cured his atrial fibrillation. He's planning a wedding, he's pursuing a master's in mechanical engineering, and he has a high-pressure job requiring 24/7 availability. Now his heart can handle it. And his dad, too, no longer lives life with an irregular heartbeat. Dr. Rowe performed a catheter ablation on John, bringing his heart rhythm back to normal. Although catheter ablation was the answer for John and JJ, each person is different. If there is one commonality, it is the dedication by the experts at the Regional Heart Center to find the best treatment for every patient in their care.
We have fantastic surgeons, we have fantastic interventionalists, heart failure physicians, congenital heart specialists, and general cardiologists. Because of the many different types of arrhythmia presentations, I can think of many cases where we really had to combine our efforts and think out of the box, so to speak, of the conventional treatments available in order to get patients through a very, very difficult time.
For J.J. Zevenbergen, that time is in the past. Now it's all about the future, as it is for Joanne Wallow and her growing family, and Jerry Allison. 3 patients with 3 stories, 3 lives that were changed for the better by one world-class team.